Oh my God, exam. Welcome to class number 10, Beta Thalassemia Part 1. This is the classification of thalassemia, both beta and alpha thalassemia. I would like you people to kindly by heart this. Now, basically the beta thalassemia is divided into thalassemia major and thalassemia minor. Major will be about homozygous types, whereas minor will be heterozygous. And this is quite severe request requiring regular blood transfusion, and it is a rare type of gene deletion. Alpha thalassemia we shall be seeing in the respective class. Now, what happens is when either of the parent carrying a defective gene and then there is an offspring of it that carries both the genes as defective, there is a full-blown beta thalassemia major. Otherwise, it happens to be a trait. When there is no defective gene, there is no trait in the patient. This particular classification by heart. Thalassemia by itself is defined as a heterozygous disorder caused by mutation that results in the defective formation of hemoglobin. Beta thalassemia, hemoglobin A is defective. Now, this is a geographical distribution. You find that it cuts across the Mediterranean Sea, involves India and the other countries. That is why it is sometimes called as Mediterranean anemia or the Cooley's anemia. The chains are coded for in chromosome number 11. Clinically, there is a classical failure to thrive. The skeletal changes are due to expansion of the bone marrow spaces. There is a widening of the diploid. I shall be showing it. And that results in frontal as well as malar prominences, malocclusion of the tooth also. Splenomegaly, hepatomegaly are compensatory. Jaundice due to hemolysis, puberty due to malnutrition can be delayed, and anemia and infections are common. This facial representation is called as mongoloid faces or chipmunk faces. Look at the frontal and the occipital bossing of the skull in this case, and the masosplenomegaly in a patient with beta thalassemia. So this is what I had said. You find that this is the marrow space. There is an outer table and an inner table. And in between is the marrow space. Owing to anemia, there is an expansion of it, and that causes this kind of a widening of the skull bone. At the same time, there is a reactive new bone formation, which results in a hair-on end appearance. This is an important picture or a pathogenesis that you people shall and will know. Normally, you find that there are the alpha chains and the beta chains, pairs of each. Now, when both are in adequate quantity, you find that they are in a soluble form. When something is defective, then the other gets precipitated. And what happens is there is a microcytic RBC which carries the defective hemoglobin. And when it passes through the splenic sinusoids, it is pinched off. There is a hemolysis that happens. The hair-on end appearance I told you in the earlier slide itself. Extramedullary erythropoiesis can happen because of the severe anemia. Erythropoietin is also being produced, but the patient will be requiring repeated blood transfusions owing to massive and recurrent hemolysis. Also, because of it, there can be an increased amount of iron absorption because of depletion. At the same time, the patient is also transfused with blood. Therefore, he can end up with hemochromatosis or hemocirrhosis of the organs such as the heart and the liver. What you people will have to explain will be increased phagocytosis, decreased beta globin synthesis, and hyperactivity of the spleen. We shall go to the next class.